You don't have to.
Happy to do that. I was also in the band, so my voice carries. I was a section and squad leader back in high school. My job today is to hang out with y'all and, of course, let you know a little bit about my life and career and my work as a psychiatrist. I've spoken to lots of students throughout the years. I can tell you that I was not a pre-med student. I did not ever think that I was going to go to medical school. So my journey maybe was a little bit different than some of y'all. But I'm happy to tell you a little bit about my journey, how I got here. But mostly I just want to answer questions that you might have. So I'll tell you a little bit about my background, all the work that I do at the med school and the work that I do within psychiatry, and then you can think about what might make sense as far as questions that you might have. However long you want me here, I will happily stay, and then I'll go home and hang out with my nephews and folks that are visiting. So I'm here to answer your questions. So I'm a native Texan, born and raised in Houston. I'm the first in my family to be a physician. So I'm not the first in my family to go to college, so I'm not first gen in that way, but certainly we still don't have anyone else in my family right now who is a physician. So I really had a very limited experience or even knowledge about what a doctor was. My family didn't really go to the doctor very often, and so my experience was Houstonians, but I went to kind of a central Houston high school, graduated from there and ended up at Rice University, so I got my degree at Rice. I was a chemistry major. Because I really liked my high school chemistry teacher. I thought that she was pretty cool, and she always thought chemistry is cool, and I ended up being a chemistry major. And by the time I made it to the summer between my junior and senior year, I realized I needed to figure out what to do with the chemistry major as I was getting closer to graduation. And I took the GRE, I took the MCAT, and decided that I would apply to grad school and to med school and see what happened first. I hadn't taken any biology classes by that time. I was almost a senior, hadn't taken any biolab, nothing. And so I spent that summer doing that and taking an MCAT prep course and kind of talking to the med school people that were there and trying to figure out my way, and did the Texas match, which y'all I'm sure are familiar with, and got into med school before I got into grad school and gave it a whirl. Again, really not super traditional in the med school kind of route. I went to med school in San Antonio and really enjoyed learning. I really enjoyed and clearly I'm a nerd like that. But I very much enjoyed the human behavior and psychiatry coursework there in the first year. And fell in love with it, but because I wasn't never thought I would be a physician, I never thought I would be a certain type of physician. I was open to all experiences. I fell in love with everything, and psychiatry was the first rotation that I did in my third year, my first clinical rotation. I really, really loved it. Did consult liaison psychiatry, so that's when you are on the in the med-surg hospital, and you're providing a psychiatric consultation for those patients that are admitted for medical and other types of needs. So we're helping those teams take care of their patients who needed their mental health addressed. It was the first thing that I did. I really, really liked it, and I really liked lots of the clinical rotations because that's really where you get to see what it's like to help people who are ill. I didn't love women's health, so I apologize for those who are going to be women's health providers. That's just not that was not my passion. But by the time I made it to my fourth year of medical school, I was deciding whether I wanted to be a trauma surgeon, which is very different than psychiatry, right? Like that's not aligned. Like I did a trauma sub-internship. I did a medicine, internal medicine internship, sub-I, and I did psychiatry and really fell in love with psychiatry. And decided that was going to be what it was for me. So I applied to residency, did my residency experience in Dallas at UT Southwestern. So I did my training there. And along the way, really in my second year of psychiatry, I was open to all of the different specialties of psychiatry. So to be a psychiatrist, you're taking care of the mental health needs from the smallest child to the older adult. You are treating folks that may have substance use issues. They may have forensics needs, maybe perhaps they have criminal charges, or you are concerned about their ability to make decisions, and so a psychiatrist can help decide whether or not someone is thinking clearly and can make decisions. A psychiatrist is responsible for caring for folks with depression, ADHD, bipolar disorder, schizophrenia, and kind of lots of things in between. And so the specialties of psychiatry include child and adolescent psychiatry. I thought that maybe I was going to do that. Forensic psychiatry, which really deals with more kind of folks that might need kind of help within the legal system. So maybe those are incarcerated folks or folks that might need a psychiatrist to testify for them in court. Other specialties of psychiatry include consult liaison psychiatry, which really work to help with medically ill patients. So they're in our hospitals, the psychiatrists that are there. And then geriatric psychiatry, which is really focuses on taking care of older adults. And so in my psychiatry training, again, I never thought I was going to be a psychiatrist because I never thought I was going to be a doctor. I fell in love with geriatric psychiatry. So I'm a geriatric psychiatrist. There are not very many of us in the world, in the country, and when we really specialize in caring for folks that are aging. And so you can have psychiatric illness beginning quite young when you're a child, or perhaps in college, or kind of soon after that. But you age with that illness, and the types of medicines we use get more complicated as we get older because our body is changing. I know many of y'all probably taken your physiology classes and know the aging body doesn't, the kidneys don't work as well, other things happen, you might have cardiac issues that make it really challenging for us to prescribe our medicines in the same way that we do when someone's younger. So a geriatric psychiatrist specializes in that care. We tend to see more patients that are medically ill because as we age, we tend to have more medical problems. And so we could be seeing people that have never had psychiatric illness before, and the first time ever having an episode might be later in life, or perhaps they've always had psychiatric issues. So geriatric psychiatrists are kind of like detectives. We have to figure out what's going on and why maybe it started now, and think about the interplay between their medical concerns or perhaps neurological concerns and why they might be influencing their psychiatric symptoms. We also take care of folks who have conditions like Alzheimer's, Parkinson's, other types of more rare dementias, things like Lewy body, vascular dementia, those types of things. And those types of patients, we diagnose them, we treat them, we provide assistance to their families that are managing those conditions and caring for those patients in their home. And so we tend to work on teams. We work with primary care and neurology and other specialists to best care for folks as they're getting older. So I did in order to be a geriatric psychiatrist, you have to do an additional year of psychiatry training. So psychiatry residency is 4 years. So you do 4 years to learn to be a general psychiatrist, to manage anybody, any adult person. And to specialize in psychiatry, you do additional training. So that's a 5th year, so 1 additional year to be a geriatric psychiatrist. And that was the 1 year I left the state of Texas and went to Washington State, to the University of Washington, so in Seattle, to do my geriatric psychiatry training because I wanted an experience that was outside Texas. I wanted to see what I might be missing as far as kind of legal ramifications of taking care of someone in another state, right? They have different mental health laws, different ways you treat patients. I wanted to work with different researchers and specialists, and so when I went away to Seattle, and when I finished my training, my husband had started a company when he was in med school with one of the husbands of one of my med school classmates. They had started in San Antonio. I relocated to Austin because Tech Austin, ended up here. And so we ended up here in Central Texas. And I joined the teaching faculty here in Austin as part of the psychiatry residency program 15 years ago. So I've now been here for 15 years teaching and training. Teaching and training students, medical students that have come through, now through Dell, but previously through A&M and UTMB, We had students doing their clinical rotations here in the Austin area, and we would help teach those students. Also teaching the residents, the psychiatry residents that are here, learning to be psychiatrists. And in my work, my everyday work, I'm an outpatient psychiatrist, meaning that I manage patients in our clinic, in our training clinic, and I'm employed by Ascension. So Ascension pays me my salary. I am the clinic director there at Ascension, and the residents rotate with me in my clinic, and I 50% clinical, and the rest of the time I'm administrative. So that administrative time, I'm either teaching, like I taught last week, a couple of lectures on Lewy body, and I'm teaching next week about a couple of things. So I'm teaching the residents and the students as well. I'm running the clinic, so it's working with the clinic staff and making sure we have our proper policies and everyone's informed about what to do. But I'm also the program director for our geriatric psychiatry fellowship program. So here, I guess 4 years ago now, I built the training program here locally to teach psychiatrists to be geriatric psychiatrists. So my job also is responsible for training the new generation of geriatric psychiatrists here in town. At Del Med, I am on the Medical Student Advancement Committee, which means I am responsible, one of the faculty members responsible for promotion and graduating. So if students are doing well, they go promote year after year, and we're excited to graduate them. But if someone is struggling, we help to give them guidance and decision making of whether or not they should take a leave or repeat a year or repeat a class, those types of things. And this year, I'm a new member of the Admissions Selection Committee, which means I get to review your applications, should you apply to Del Med. I get to review, I get to review how you did on your interview day. I get to read your personal statements, and then we get to rank how you guys fit within the world of Del Med. And so for the year, in past years, I used to be one of the interviewers. I was one of the, what it starts off with, we review your application in general and decide if you're a good fit, and then whether or not you get a video interview, secondary video, and then whether or not you come, or I guess virtually now, and do an interview. And so now I'm part of the final committee that actually reviews all of those steps and decides where people fit within the med school. So I do a lot of things here locally, but I'm also part of our national organization, which focuses on geriatric psychiatry. So I'm one of the chairs of the subcommittee on resident education for the teaching and training committee, and for the American Association for Geriatric Psychiatry. And I was recently the chair of the program committee, which puts together our annual meetings. For the last 2 years, I've been responsible for putting together the annual meeting. So I wear lots of hats. I've come in contact with medical education in lots of different ways. Folks have asked me lots of questions throughout the years about why I wanted to be a psychiatrist, why geriatric psychiatry. So it's always fun to get to know y'all and kind of the questions that you might have. My passion is teaching and training, and that's what I love to do. And I think that geriatric psychiatry is super cool. That's my why. Patients are more complicated, how we approach them, what we can do. We tend to be more innovative. The patients are often sicker. They need more care from us. And it's a great way to learn how to be a great psychiatrist. So I'm a little bit biased. I think geriatric psychiatry is super cool. But I know you probably have lots of questions for me, or you don't, because I've given you all the answers. But I'd be happy to answer anything that y'all might have, any questions y'all might have. Oh, right away. Yes, ma'am.
So with geriatric patients, do you often go through loss of a patient, and how do you deal with the grief that comes with that?
No, that's a great question. Yeah. In medicine in general, and in psychiatry in general, we tend to have loss, right? So it's not unusual for us, and especially in geriatric psychiatry, for our patients to be medically ill and to die from medical illness. And so we often hear from family members kind of after an event like that occurs. They often thank us for helping and to make especially if someone's at end of life, make that end of life experience better for the patients and better for themselves, for the rest of the family members. So on my end, and when I know that someone's been sick for a long time, or say they've had Alzheimer's for a very long time, there is a little bit of that double-edged sword. You know that they're not in pain and distress, they're not struggling in that same way, and so that they have kind of relief and the family has relief after a loss like that is really important. And sometimes we get invited to their services and things like that, so if we can go and it's not kind of a burden, then we may decide to go and see. Most of the time we don't get invited, or even if we do, we don't necessarily go because there's just too many other things that we're doing. But we'll send a condolence card to the family, kind of thank them for being allowing us to be part of their lives, and really kind of show our appreciation. I think the hard part, and if I step back as a psychiatrist, there's many times where a loss is much more traumatic for us and the family. And as a psychiatrist, I'm talking about things like suicide or dying by homicide or other types of kind of traumatic events, or even like a car accident where you don't expect someone to pass. You would think that having a patient die by suicide would be a really challenging event, like the family would be mad at you, or it would be like a really awkward or awful kind of experience as far as how you interact with a family member. But many times, especially when you're working so closely with a patient who's so sick, and you work so closely with the family members to support them, even when someone passes and dies, the family members are extremely grateful for all the work that you've done. It does not make it easier to have a patient who dies, and who dies unexpectedly and traumatically. And so on our end, we're actually talking about this now in terms of our training program, making sure that we have procedures in place so that we all have support. You have to have your team, the people that you talk to in your peer group, your colleagues that you can go to when you're bummed out. It's important for us to have our humanness, so we will cry, we will be sad when someone passes away, especially when they've meant so much to us, or we've worked so hard with them. But you also have to have your support that's outside of your work group. And so for me, that means that I have my husband, I have my non-work friends, I do my non-work things, which means I'm going to Pilates 3 times a week. I have my dates, I have the things in my life that make me human. We were out on the boat today with my nephews. You have to do those things to be human and to just not kind of live in that shell of medicine. And so there's different ways to do that, but loss is one of those things that kind of you never get used to, but it's part of the experience of being a physician. Thanks for your question. You had a question.
Yes, I was just wondering if you could just talk about controlled substances, your views on them, and if there's certain things that you would have prescribed maybe 5-10 years ago that you just don't do now, and the differences you see in the regulations in Texas and in other states.
Mm-hmm. As a geriatric psychiatrist, I will tell you that I prescribe many fewer controlled substances than I would as an adult psychiatrist, or even a child and adolescent psychiatrist. So controlled substances would be things like stimulants for ADHD, it could be sleep medications, so some of our sedative hypnotic medications, and some of our anxiety medicines, so our benzodiazepines, those types of medicines would fall under the controlled substances. So as a psychiatrist, I don't prescribe opiates. So opiates would also be, we don't manage pain in psychiatry, but we do have patients that are on all of those medications. So if I'm wearing my geriatric psychiatry hat, because in reality I supervise in both the adult and the geriatric clinic, so I take care of all the age ranges that are older than 18. So as a geriatric psychiatrist, the mantra of geriatric psychiatry is to deprescribe, meaning I want my patients to take fewer and fewer medications, especially medicines that are going to be harmful. And many of the medications that are controlled substances are very challenging for older adults to take, meaning they cause falls, which lead to fractures, which are no good as you're aging. They cause confusion, they can cause delirium, they can cause long-term cognitive impairments. They are not good for the aging brain. And so from my perspective, I'm not prescribing less necessarily. I'm not saying I'm never prescribing this medicine ever again. What we have is that we have patients that come to us on these medicines, and we spend the next many, often months, and sometimes even years, slowly reducing the amount of medicines they take daily, till eventually they prove to themselves that they don't need to be on them. And that process, you would think, could be really quick. You can get somebody off of medicine in a week. You can't, right? That's just practically not a thing to do. And so we haven't stopped prescribing those medications, but because there's such a growing group of folks that are 65 and older, they've been on these medicines sometimes for 40 years. They've been on the medications for a long time. And so kind of taking them off is a long-term challenge. But there's so many more people that have been prescribed those medicines, and for whatever reason, older adults are more likely to be prescribed those medicines compared to younger adults. So it's an interesting conundrum there. But if I step back and I wear my adult psychiatry hat, in the last 5 years, there's been an exponential growth of prescribing of stimulant medications. More and more people describing concerns for inattention, and maybe they have ADHD. Maybe we have diagnosed them and we missed them initially, and now they're diagnosed. And sometimes that happens, right? So if you are kind of a highly intelligent person who has always been kind of a tremendous student, you can get through elementary school without trouble. You can get through middle school. You can get through high school. But when you get to things like college and to grad school, where the expectations for kind of work and kind of how much work you have to do and how more challenging it is, sometimes we do diagnose people in college and in grad school who've never received treatment before. But if you gave me a stimulant, I'd be super awesome. I don't have ADHD, right? But if you gave me a medicine that made me kind of give me more energy, allowed me to stay up and study longer, and for me to kind of turn on my mind more, or focus harder, I probably would be super cool, right? Or cooler than I am now. How about that? And so it's really hard. You get really stuck because people do try these without prescriptions. They tell us that it helps them, because it certainly does. And so sometimes people will say, that's the reason I know that I have ADHD, because I took a stimulant, somebody gave me one. It was so much easier for me to do my work. And so it's not a diagnostic tool, all right? So it's not meant to say if you get a stimulant that you do have ADHD. So it's really getting challenging because there's been so much more prescribing. There's been challenges for people to get their medications. We run out of medications. People can't find their medications. People who really truly have ADHD need them. There's been, because of COVID, we now have telepsychiatry. You can see providers, and maybe even just fill out a form when they diagnose you with conditions like ADHD, and they can prescribe these medications, and these numbers of folks that are getting these medications are definitely more and more and more. I think the DEA is trying to decide how we're navigating that kind of virtual prescribing. They kind of walked back the expectation of you have to be in person to get this prescription, at least seeing someone within 6 months. They got a lot of pushback. Psychiatrists really liked working virtually and wanted to keep doing that, and so we're now in this gray area of what's actually going to happen, but there haven't been tons of regulation changes, other than we need to review what controlled substances the patient gets per month. And when we prescribe, I have to review that before I send a prescription to the pharmacy, right? And so in our clinic, we don't prescribe early refills. So if somebody's telling us they ran out early, they only get a 30-day supply, and we won't fill it until it's time again to get it. Doesn't matter if they choose to use more. We're not going to prescribe it. If somebody falls in that pattern that they keep asking for it early, and they're showing us that they're misusing it or abusing it or perhaps diverting it to other people, then we're not going to continue to prescribe it. But those are all internal policies that we have as a clinic, and I'm sure other clinics do as well, but they're not required. So it's an interesting world for them, yeah.
It's sort of on the same topic to this, but sorry. Telehealth visits. What is your opinion on that? And like, especially like, you can't do a lot of things that you would normally do in clinic, like a UDS to for some of those controlled substances.
That's right. Telehealth is been so impactful for patients who had challenges making it to clinic, right? So if you'd imagine meeting someone where they're at, allowing them to kind of make it to whatever physician's office they needed to be, but not actually in the office, and kind of get the care that they need at the time. The challenges with telehealth is that, disparity, like who could actually access it, like who actually had the bandwidth to support like doing a virtual visit, who actually had private spaces. And I think about you guys as students, like, do you have roommates? Could you have a private conversation with a psychiatrist and air all your dirty laundry? Or perhaps you were living in a situation where someone was you were being abused. Could you tell your doctor and be confident that you would be able to share that without other people knowing? That stuff gets really tricky in those virtual appointments. Funny business happens. Like, people have a virtual appointment and they'll be driving a car down the highway. Like, you cannot have an appointment with us while you're driving a car. That's just not safe. You cannot do that. So we'll reschedule. And in our geriatric clinic, because our entire clinic went virtual when we shut down, our older adult patients really struggle with technology, right? So it's not just, do you have access to technology? Do you have the bandwidth to use it? But can you actually navigate that to have an appointment? And so we'll do things like we'll have them get their weight, show us what their weight is at home. Our patients have purchased blood pressure cuffs. We'll have them go to the lab. We can send orders to the lab. They can go to the lab. So we can do a lot of those things. But in our clinic, we ask all of our patients, our adult patients, to come back every 6 months so we can have an in-person visit. They can come in, I can see them, I can do a physical exam because I can't do a physical exam virtually. We'll get their weight. Many of our medicines cause weight gain, so we want to monitor that. I can check them for side effects of the medications, things that I can't do as easily virtually. For our geriatric clinic, I asked all of those patients to come back in person. It was too challenging in maintaining our schedule, but we were missing a lot. We were missing conditions like Parkinson's. Like, I really needed to see how they walked, and that was really hard to do on video. I really needed to do a physical exam. We missed a lot of stuff that we would have hopefully would have caught in the office. And so we've asked those patients to come back. And there are going to be certain times that we ask patients not to have virtual appointments because we need them to come in, and that's just part of the expectations. Yes?
How do you go about treating those Alzheimer's patients?
Man, that's like, that's like a whole course, right? I don't, is there a particular aspect that you are, is there a particular aspect about treatment or the types of symptoms or that you're curious about?
Yeah, I guess like what a typical appointment would look like if you already were suspecting it.
Oh, no, that's a great question. So our conditions like Alzheimer's are what we call, and actually all of our psychiatric conditions are what we call diagnoses of exclusion. Meaning, in order for us to decide that they have a psychiatric condition, including Alzheimer's, we have to prove that they don't have something else that would cause those symptoms. So when someone comes in for what we call a cognitive assessment, the first thing I would want to know is there anything that could be causing those symptoms that's reversible? So we're getting the story of what's happened, we're asking the family what they've noticed, what changes have happened, what's going on, what's the decline that they notice, how have they been struggling with their everyday tasks. So we're getting the story. So besides collecting the story, we're also evaluating. We're asking them to go to the lab. We're getting a full panel and lots of labs to make sure that they don't have thyroid issues or vitamin deficiencies or an anemia or something that could explain why the brain was not working as well or why they might have cognitive troubles. We're also getting things like an MRI or even more kind of fancier scans, so things like functional neuroimaging like a PET scan. So we're getting that information as well, and we'll ask them to also meet with a neuropsychologist, so a psychologist who's going to do in-depth testing to tell us what areas of their cognition are working well or what areas are not. And if they are performing below what we would expect for their age and education. And in reality, we want to know if it's a change for them. If you've always had trouble with, let's give you an example. My husband struggles with directions. He's never gonna be, you ask him what direction we're going, he's gonna get it wrong. That's not gonna change between now and 20 years from now. He's gonna be awful at it because he's just never been good at it, right? But if somebody was a taxi driver, or Uber, maybe say a rideshare driver, right? Modern day, and they never had trouble navigating, but now they do, and they get lost or get confused and have to places that normally would have taken them 10 minutes to get to, now it takes them 30 minutes. That person has a change for how they were functioning, and so that's really the most important piece. So we do that evaluation, and it's not a one-time visit thing. Like, I'm not going to be able to say in one visit for sure you have Alzheimer's, because we have to do all of those things first. And we also have to treat psychiatric conditions too. So if there's depression or something else that's going on, or sleep apnea or any of those things, we would treat all of those things first, and then we would see how much the cognition improves. And if it doesn't, then we would feel more confident, and with all of that other workup, we would feel more confident with the diagnosis of Alzheimer's. So it is a clinical diagnosis, and it specifically impacts memory and learning, and it's new information. So remembering what somebody's second grade teacher was, or where they grew up, or what their parents' phone number was, or whatever, that's not a sign of Alzheimer's. Alzheimer's means that if I gave you a new thing to learn today, you wouldn't be able to remember it because it never got stored. The hippocampus doesn't work properly. And so you putting all of that together could make a decision about Alzheimer's. Now, in the last 5 years, in the last really few years, 3 years, we have new medications available to treat the earliest stages of Alzheimer's that really target beta amyloid, and the hope is that it will, and what we've seen is actually patients do better clinically because they're having kind of less of that neuronal loss, like the beta amyloid hypothesis is that you're going to have inflammation and consequences of that deposition of beta amyloid, and then eventually you're going to have atrophy or brain loss in all areas of your brain. So instead of just starting with the hippocampus, it's going to spread everywhere. So if we know who those patients are early, and even if we knew who was going to get Alzheimer's before they showed us any signs, then we could potentially stop that from happening. We're not there yet, but now we're treating the earliest stages with those new medications. So that's a new thing that's happened in the last 3 years. And they do provide that here at vet school. Yeah, it's cool stuff. Mm-hmm.
My question was about how you said you were kind of interested in trauma and psychiatry.
I know.
Like, looking at it from my perspective, I see it as like trauma as like this, let's work fast, what's like, the thing that's happening, where psychiatric is more like, all right, tell me about how you're feeling. It's like the slow process of like months to years to really understand the condition, right? So like, my question to you is more of like, what exactly was it? Like, two ends of the spectrum. What made you choose the spectrum of geriatric?
So when I was interested in trauma surgery, right, like the idea of helping someone like acutely in the moment make those decisions, help people get better fast, fix something that's broken, right, like that's just super appealing, right, and kind of running through like the kind of protocol of like, ABCs, like what's their airway, what's their breathing, all that sort of stuff. So that kind of that formulaic, like in the moment, you guys have seen lots of medical TV shows. Like you've seen people like work in the emergency room. It's kind of fun and exciting in that way. I like the being the detective. I like the trying to figure out what's going on and taking action, right? But you're right, as a psychiatrist, that action is like, it's the slow game. Like it's like as a geriatric psychiatrist, it's a little bit of both. Right, so as a geriatric psychiatrist, there's often so much medical stuff that's going on that's the cause of the psychiatric symptoms they're experiencing, that like I get to do both. Like a resident will tell me a story, the patient's coming in, she's starting to have more hallucinations. She's had hallucinations in the past, but it's been a few years since she's had that. And what I know of the patient, because I've known her for years now, is that every time she has a bladder infection, she gets these symptoms. But we also reduced her medication a couple times ago. So is it that we're not treating her enough? We lowered the medicine? Is it she has a bladder infection? Or could she have something else? Could it be a start of a dementia? It could be any of those things. And as a geriatric psychiatrist, I'm on a mission to figure out which one it was. She did have another bladder infection. So it's in the moment, then and there, all right, so she needs a course of antibiotics. So that's the treatment. And then coming back, she's gonna come back and see us in another few weeks. How's she doing? How's she feeling after that experience? It's both, right? And so that's the cool thing about geriatric psychiatry. I don't know if that helps.
Yeah, that's interesting. I'm kind of seeing it more like a med surg type thing. You have the same patient that come back. Like the moment they come back with like a different condition, you're trying to treat that. So like a mix of both ends.
Yeah.
Sounds really cool.
It is really cool. See, geriatric psychiatrists are the rock stars of psychiatry. Just kidding. Yes, ma'am.
So was what appealed to you about psychiatry more of the long-term aspect of it? And then if it is, then I'm just curious, how many patients do you guys take before you guys don't take more, like new patients?
It's a great question. You would think that the reason I chose psychiatry is the long-term aspect, but in reality, as a medical student, we don't actually get a whole lot of longitudinal exposure to patients. And in fact, in psychiatry, there's not a lot of exposure to outpatient psychiatry. So like, I had no idea what it was like to be an outpatient psychiatrist. And most residents, when they come to clinic, and most students, when they rotate with us, unless they have their own psychiatrist or someone in their family who's needed a psychiatrist, what happens in the psychiatrist's office, including things like therapy, is a mystery. And so it really wasn't that, because I had no exposure to it. So I had no idea what it would be like. For me, the human condition is fascinating. And people's stories in their lives are amazing, right? And so as a psychiatrist, I get to sit there, and my husband makes fun of me sometimes, I get to sit there and get all the tea, all the gossip, like what is happening in their family, and who did what, and like literally, there's just, you get to know so much about patients and their families, and all, sometimes it's juicy, sometimes it's sad, sometimes, and that's really not about the juiciness, but really psychiatry, you're laughing, maybe it is, but psychiatry gives you the time to do that, to get to know patients. And if I have a therapy patient weekly, I get 50 minutes to get to know them and their story, and get to do that every single week. And as an outpatient psychiatrist, I have people that come and see me once a month. I have some people that come see me once every 6 months. So it's kind of in between, and it's so cool to hear updates and like, what's been going on in your life since then? And how have you been? So that part I think is really cool. You asked the second part of your question that I can't remember what it was.
I think it was, well, I think you might have answered it because you said you work in outpatient. It was just like, is there a stopping point?
No, that was a great question. So as an outpatient psychiatrist, like, I could be shut down for, I could fill my clinic up like immediately and not have room for new patients. In kind of as clinic director of our training clinic, it is not useful for the residents to see a stable patient or only see stable patients every 3 months. If they're just prescribing the same stimulant, the same antidepressant, the person's been well for years, there is a learning experience, don't get me wrong, like that there is good learning and value there. But where we learn the most, where our trainees learn the most is by doing the evaluation. What's going on with the patient? What's their diagnosis? And coming up with a treatment plan and doing that all kind of as part of the first visit and having those patients follow up and see how they do, and making changes over time. That's where you learn the most, when someone's kind of in the process of having acute symptoms. So in our clinic, once someone is stable, meaning that we're not changing medications, we found the medication that works best for them, we ask them to return to their primary care doctor, or we ask them to find a community psychiatrist if we don't think that the level of care kind of needed would be good for our learners. Okay, so really I prioritize what our learners need, and so that patients should expect to be there for a year or a couple years, and then plan to transition out of our clinic. So that's the way that we manage it. In my clinic, I have a little bit of clinic time every week, like a few hours at the most. And so I don't have a whole lot of time for new patients, because I just don't. Most of my clinical time when I are in clinic is staffing the training clinic. So meaning I see the patients that the trainees see. So my own clinic is very, very small. And so I've had patients who passed away. And when I started here 15 years ago, I had much more clinic time. And now as I've done all of these other things, my clinical time is shrunk, as my caseload is shrunk as well. And occasionally I have a new patient. Somebody will ask me to see someone, or I saw a patient at the hospital when I work on the weekends. And so then I'll have them come into my clinic. And sometimes patients that were doing well end up needing us again. I just had a patient who I saw from 2016 to 2018 reach out this last month to come see me again, right? It's been since 2018. So they're back again for me. It's a lot of years. It's almost like a new patient. I'm a detective again, trying to figure out why is this patient here and why do they need me again? So we have patients that kind of float through and they'll come back after being away for years. But we can't, we have to transition our patients back to the community to allow us to see more patients. And our clinic is the discharge clinic for Shoal Creek Hospital. So Shoal Creek is one of the psychiatric hospitals in town. So as patients are admitted there, when they leave, they need a psychiatrist to manage their condition. And many of those patients that come to our clinics, we have to make room for them. So that's the why.
Okay. So there's this thing that I've heard that like physicians are the most like sympathetic, empathetic person, but also they shouldn't be. And also I guess the latter part of the question I'm trying to ask is there a certain personality to be a psychiatrist? Because I feel like, oh my gosh, if someone's crying, I'm crying. You know, like so unprofessional. You're getting mad, I'm getting mad. So like, like.
So you can't get mad at all of them, right? And you can't cry all the time. But so what I usually tell students, the med students that rotate through, and even the residents that rotate through is, I'm a human. I'm gonna have days that are bad days. So you come to see me, I'm not gonna be feeling at my best. I'm gonna have days that are my great days. I'm gonna feel awesome. Some people feel really strongly that they need to be their professional persona Like they have to look and dress and be a certain way, and being a physician means this one thing. My philosophy is the opposite. I'm me, right? So when somebody comes in the door to see me, they're seeing me, which means my patients ask me how my holidays were, what trip I went on, how's my husband doing. Like, I'm me, so they're gonna joke around with me. There's some patients, like, they're gonna cry. I'm gonna cry because it's sad, right? Because I'm human. On our end, it's important for us to recognize our emotions, because sometimes when patients make us feel a certain way, we have to know that that's going on, because it could really influence us. So if a patient is really upset and they're crying, like if you're crying, or maybe the better example is if I'm crying and I'm a hot mess in the room, I might want to just do anything I can to make that stop, because I'm uncomfortable, right? Because as a provider, you're uncomfortable, so you want me to stop crying. So you're going to be more likely to prescribe things and do things and fix things. And I think what we learn as psychiatry, and part of the long game again, is I can't fix it in one day. And it's not my job to fix it. And when someone's in distress, if I can do things to help, if their psychiatric condition is poorly controlled, then yes, that's my job. But my job also has to be tolerating emotions, because sometimes your patients have never been taught how to tolerate those emotions, and any emotion feels intense. And so being able to be in the room with someone who is yelling at you, who's crying, who's refusing to talk to you, just the act of being there with them is therapeutic. But it can be very draining and very exhausting to do that. But as a bright side, kind of psychiatrists are not the most burnt out of all the doctors. There are plenty of other specialties that are way more burnt out. And you would think that there's like that emotional burnout, like people are telling your stories, you're hearing all these awful things, psychiatry must be the worst. But it's not. But you're right. There's a match, and it's not a personality that goes into psychiatry, because there's lots of different personalities in psychiatry, I'll tell you that. There's there's so many different types of people that go into psychiatry for lots of different reasons. So there's not one type of person, but you have to be able to tolerate discomfort, your discomfort, but also the patient's discomfort, and that knowing yourself as you're going through the journey of medical school is really important to figure out, like, is what I'm doing every day, does it give me joy? Like, I'm not trying to ask you to, like, Maria Kondo your house or whatever, but, like, do I want to read more about this? Do I want to learn more about this? Do I want to go to conferences to learn more and more and more and more? Do I like these colleagues? Can I imagine psychiatry people being my crew and hanging out with them? Or are these not my people? Or this is not the work that I want to do? So kind of having those conversations with yourself as you're going through the process is really, really important. Because if you don't want to read about psychiatry and all the cool things that are going on in your brain, then psychiatry is not for you. And there's going to be some other specialty that sparks joy, whatever that might be.
Thank you.
Mm-hmm. Yes.
You mentioned that you were on the admissions board for medical school applications. So, in your opinion, what do you look for in an applicant that aligns with the views of the line?
So each school has kind of what types of things they're looking for, right? So DelMed versus another, and I know that they all meet, like the director of admissions meets with all the pre-med societies and stuff like that at the different colleges. Personally, so there's things that you want to look at, kind of, are students aligned with the DelMed mission, right? So on our end, there has been a focus on research. So are you doing research? Are you publishing things, if you're able to publish things, or presenting things, like poster presentations, those sorts of things. So there has been, from our leadership, from our dean, really a focus on that. And also a focus on things like kind of beyond community engagement, but like what you're doing as far as your healthcare activity time. So when you're doing something, are you volunteering? Are you doing something more meaningful in healthcare? What are you actually getting from that experience that'll change kind of that informs your motivation to be a physician, but perhaps has transformed what you've thought about kind of healthcare and medicine and those sorts of things. DelMed specifically, from what kind of my experience now, is looking for unique folks, and many of folks that are coming from other experiences that don't necessarily go, hi, we're done, gotta go home.
Oh, I'm sorry about that.
No, it's okay. So they're looking for folks that have had different experiences, like people that have been in the Peace Corps, people that have done this, people that have done that. So part of that. Are y'all like fighting each other? It's amazing. So part of that's really, really important. On my end, when I read an application, I really want to understand your motivation. Why do you want to be a physician? What's your story? And it's not the most, like, I don't care if you write me the most beautiful prosy essay of whatever. I really want to authentically know you. So, like, why? And so there's been a lot of essays that I've read that I have no idea why. They've told me that they've done this and they've done that and they volunteered and they did all fabulous things, but it doesn't help me understand why they want to be a physician and what those experiences have helped make that journey for them. And part of it's my bias. I'm a psychiatrist. Like, I want to know the why. I want to hear it, feel it, and all that sort of stuff. So that's kind of when I read essays, and I read essays for residency, and I read lots and lots of personal statements. That why piece is really important. So telling your story, making it a story, and making it so your audience really understands the why. That's your end.
Thank you very much.
Yeah.
It is 7 o'clock. So then, last question is, can we take a picture with you?
Oh, please.